We all know Dr. Lebwohl very well. He's professor and chair of the Department of Dermatology, the Icahn School of Medicine. He's author of over 500 publications. He's done so much for the field. He's now, president of the American Academy of Dermatology. And his expertise really has been in clinical trials in inflammatory skin disease, particularly psoriasis. And the clinical trials that have been at Mount Sinai have really been formative in the development of new therapy that really has done a lot for this disease. And I think really Mark has been the main person that is involved in those therapies and has really done a lot for the disease psoriasis. And he's going to be talking about mechanisms of inflammatory skin disease. Thank you.
Thanks, Bob. It's a pleasure to be here. It's been a privilege to work with our DermPath team, who have really, I think when I started, we had about 1,000 or 2,000 specimens a year, and that has grown to 80,000 or so. So we've really done a great job with it. Okay, so I'm going to give you an overview of advances in inflammatory skin diseases that have taken place since literally before I'm in dermatology. I don't get any money myself from pharmaceutical companies, but our department does get a lot of dollars because of the clinical trials that we do. So this is a picture of Mount Sinai, and the place where I see my patients and do most of my work is over here, and this is the view from my window. So, okay, this is a beautiful model of the pathogenesis of psoriasis that was published in the New England Journal of Medicine 6 years ago. And you can see it's a rather complex interaction of the immune system with the skin. When I first started in dermatology, we thought that psoriasis was a disease of the keratinocyte. Some really superb scientists reported on abnormal cell proliferation, and the mantra was that the cells of the epidermis normally make themselves over every 30 days, and in psoriasis, it's every 2 to 4 days. So that histologically, what you see in normal skin, here's your epidermis, and this is psoriasis. You see this massive thickening of the epidermis and the stratum corneum, caused by those rapidly proliferating cells. And it wasn't until cyclosporin came around and was used in transplant patients that we realized it's not just the epidermis, because cyclosporin doesn't do much to the epidermis, but it knocks out lymphocyte function. So this was the earliest report, 1988, and very quickly we learned that cyclosporin is dramatically effective. So there must be something in the immune system that is contributing to psoriasis. Now, what does cyclosporin do? It knocks out the whole thing. That's why you get infections. That's why you get lymphomas, and so of course it works, but it has a lot of side effects. Now, one of the earliest clues on that lymphocytes were involved and activation lymphocytes were involved came from a number of publications. Actually, Jim Kruger contributed, and Alice Gottlieb, who spoke last night at the Greater New York Derm Society, contributed heavily to those. And what happens in lymphocyte activation is this is an antigen-presenting cell, which is in the lymph node. It has to go through a number of steps. I actually think of these as keys on a door. So you have to unlock 2 of the locks in order to activate the T cell, in order to open that door. So the first step that happens is ICAM1 on the surface of the antigen-presenting cell interacts with LFA1 on a naive T cell. And in that interaction, it just hooks them, it lines them up together. The antigen-presenting cell then presents the antigen sitting on the major histocompatibility complex to a T cell receptor on the surface of the T cell, and that's one of the locks. The second lock can be any of many different interactions. LFA3 and CD2, as you'll see in a minute, takes on importance because we did have a drug that blocked that. Again, ICAM1 and LFA1 can be another one of those locks as well. So if you block any of those, you can prevent the next step that happens, because when you do unlock those two locks, you get T cell activation, T cell proliferates, releases cytokines, and the next step is that the T cell, this now activated T cell, enters into the circulation, and it goes through the circulation. How does it know to go to inflamed skin? Well, again, ICAM1 is expressed on the surface of the endothelium in inflamed skin, and LFA1 helps that activated T cell latch onto ICAM1, and then it diapedeses into the inflamed skin. In that inflamed skin, it is then activated again by the same antigen. It goes through all the steps, and you get release of cytokines, TNF alpha, and all of the steps that lead to proliferation of keratinocytes. So the first drug that we had that blocked that was called the LFAcept. And what they did is they took LFA1 and they put it on the, LFA3, and they put it on the FC domain of human IgG1. So they made a fusion protein. It was done genetically. And as you see here, LFA3 and CD2 is one of those key lock combinations, ligand and receptor combinations. And simply by the size of the molecule, it separates the antigen-presenting cell from the T cell. The two can't interact. And so we had a drug that very specifically blocked T cell interaction and worked for psoriasis. Unfortunately, it took lots of injections, and it took more than 4 months to see the peak effect, and then ended up working in about a third of patients. So it was not a huge success, and although it was a very safe treatment. Ultimately, it did end up getting taken off the market simply because it wasn't selling enough. Efablizumab was another drug that interacted with a couple of steps, and that efablizumab, back up. Oh, okay. Here we go. Efablizumab is a humanized monoclonal antibody to CD11A, which is on LFA1. So it's part of that interaction I mentioned several times. And so it blocks the LFA1 ICAM interaction in both places. It blocks the activation, and then it blocks the trafficking into inflamed skin. And interestingly, when we put patients on efablizumab, the angry lymphocytes stayed in the blood, so that if you checked a CBC, you'd see lymphocyte counts of 20, 30,000 because the lymphocytes couldn't leave. They were stuck in the blood vessel. And then, of course, it blocks the reactivation as well. And again, that drug was on the market. And when those two drugs were on the market, this is a slide I like to show because here were drugs that worked okay. They were not great. They were nowhere near the efficacy of the drugs we have today, but they were much safer than methotrexate or cyclosporin. So I call this is the drug companies dragging the dermatologists to the altar of biologic therapy. And did it work? And the answer is, even at that time when we had drugs that were frankly mediocre, when we started out, this is just when those drugs were approved, they only had 1% of the market. Methotrexate was 43%. 4 years later, they had 56% of the market. Methotrexate was 23%. Now, by then, the TNF blockers had come out, and they were significantly more effective. Here are the TNF blockers, and there are actually 5 of them now. Infliximab, golimumab, and adalimumab are monoclonal antibodies. Etanercept is a fusion protein, and the latest one, certolizumab, is a pegylated. Here they get rid of the FC portion of human IgG, and they pegylate the FAB fragment. Why can't you just put the FAB fragment in? Anyone know? It's very short-lived. If you just injected the FAB fragment, it would disappear in seconds. So they had to pegylate it, which gives it a long half-life. So here's where back to our original drawing, here's where the TNF blockers work. They block a lot less of the immune system. So they are certainly safer than methotrexate or cyclosporin, but they do block more than LFAcept and infliximab. And certainly with LFAcept, we were not seeing opportunistic infections or any of the consequences of immunosuppression that we see with cyclosporin or even methotrexate. Now, here's how they work, and this is Infliximab, and here you see it binding to both soluble TNF-alpha and to membrane-bound TNF-alpha, and it is dramatically effective. This is actually the second patient with psoriasis ever treated with Infliximab. There's a patient of ours, that's before and after, dramatic benefit. Despite that, the company that made it at the time, which was Centocor, wouldn't give me any to try, but Alice Gottlieb was more persistent than I, and she did get it, and it did work very well. Dramatically effective therapy. So the next drug I'm going to talk about is ustekinumab. So ustekinumab is an antibody directed against the P40 component of what was originally thought to be IL-12. So the makers of ustekinumab thought that they were blocking IL-12. In fact, that P40 component is also an IL-23. So the molecule, as it turns out, blocks both, and it turns out IL-23 is probably the key step. But here's where it works. So it blocks IL-12 and IL-23. So now we are blocking much less than the TNF blockers. And so we have a molecule that at least theoretically should be safer, less immunosuppressive. We should see fewer side effects, and dramatically effective. Until recently, the most effective drug we had for psoriasis. Here are some of the publications. Now, if you look back at our drawing, IL-23 acts over here where it causes the Th7 T cell to create IL-17. And it turns out that that is a key step in the development of psoriasis. So ixekizumab and secukinumab block IL-17 directly. And then brodalumab is a drug that blocks the receptor for IL-17, which is sitting on the surface of the keratinocyte. Here's the papers for the secukinumab trials, ixekizumab and brodalumab, and here's what we can do with those drugs. And this is actually a very average response for those drugs. Here's a patient with psoriasis, 28-year-old patient, and this is 4 weeks later. So it's a profoundly effective therapy. Until now, I've only spoken about psoriasis. The same map that I showed you in the New England Journal of Medicine for psoriasis was created by Emma Gutman, who's done a lot of the work in atopic dermatitis. And so you see a different soup of cytokines leading to the changes that lead to spongiosis and all the consequences of atopic dermatitis and eczema. This is a patient before and after cyclosporin. This patient actually ultimately went on to commit suicide because of his eczema. We couldn't keep him on the cyclosporin because of its renal effects, and he actually ended up committing suicide. It's a terrible disease. Back to our drawing. Here's how cyclosporin works. It blocks the whole thing. It blocks all lymphocyte function. This is a child, and you can see dramatic before and after on cyclosporin, but he does not like the blood checks. He needs all the time for that. And here's a list of the side effects. Now, on this list are, I don't even list opportunistic infection, which is a real side effect of cyclosporin. Lymphoproliferative disease, though, is the one that gets a lot of attention. And as you know, there's a huge increase in lymphomas, about more than tenfold, and a huge increase in squamous cell carcinoma within skin. In fact, transplant patients on cyclosporin after 10 to 20 years, more than 50% get squamous cells. The leading cause of death in Queensland, Australia, among kidney transplant patients is metastatic squamous cell carcinoma of the skin. So real side effect of cyclosporin. The two side effects that we worry about acutely are its effect on the kidneys, which is why both the package insert and the guidelines say that patients should not be on this drug for more than a year. And I will say that it's not like, 6 months off or 11 months off and then you give yourself a break and you go back on. You're knocking off nephrons. So you get glomerulosclerosis. So if you're on it for, 6 months, 6 months off, 6 months on, 6 months off, you're still knocking off those nephrons. You're reducing renal function. Having said that, the guidelines also say that under circumstances, there are patients who you simply can't get off the drug. And certainly before we had one of the drugs that we can credit Emma's work for, I had a large number of patients on cyclosporin for atopic dermatitis chronically. They'd been on for years, and I had the conversation with them over and over again. We kept a close eye on their serum creatinines. But fortunately, today, none of them are on cyclosporin because they're all in our trials, and they're all clear. Everybody always gets excited. They see sexual frenzy on that list. Give me the cyclosporin. Only been reported in Michigan. All right. So along comes, Emma demonstrates that IL-4 and IL-13 have a critical place in the development of atopic dermatitis. And dupilumab is sitting on the shelf of a drug company, not having anything to do, and it's an antibody to IL-4, they thought, very much like the ustekinumab story. They did test it. We actually were the first site, or certainly one of the first, if not the first site, to test it a number of years ago. And there's IL-4 blocking there's the antibody dupilumab blocking not only IL-4, but it turns out it shares a receptor with IL-13. It shares a ligand with IL-14, with IL-13. So there you see it blocking both cytokines. And here was the study. And I still remember the first patient at the lowest dose, because this was a dose-escalating trial, with the first injection was dramatically better. It was just a miracle. I never seen anything like it. So the study was dupilumab with topical corticosteroids compared to placebo with topical corticosteroids. This is the study design. It was given by sub-Q injection weekly for 4 weeks. The endpoints were the EASI-50, IGA less than 1, and a SCORAD. In terms of side effects, you'll notice that there were more side effects in the placebo group than in the dupilumab group. A really benign drug. And when do you do a study where 100% of patients with atopic dermatitis achieve an EASI-50? Well, that's what happened here. And it happened to every one of my patients. Every patient I put in the trial got better. And you see it did the same with the SCORAD, EASI scores, pruritus scores, it's dramatically effective treatment. Here are the IGA scores as well. And you see that the use of topical corticosteroids is dramatically less in the dupilumab group than in the placebo group. So at the end of that first trial, the drug company must have figured out, well, if it works for eczema, it's going to work for asthma. And they ended the trial and went, and they did pursue some trials in Europe at that time, and then went right into asthma. And this was published in the New England Journal of Medicine a couple of years ago, and undoubtedly we will be seeing this because it was profoundly effective for asthma as well, which when you think about it is like eczema of the airways. Now, there are other cytokines on that map that Emma drew. IL-31 has emerged as a key cytokine in pruritus, and that has also been tested. And here's a phase 1, again, single ascending dose study, single injection, and there were no adverse effects of note, and a dramatic impact on pruritus. Dramatic improvement in sleep, dramatic reduction in the use of topical corticosteroids. So again, profoundly effective treatment and being pursued right now. IL-22 is another one that we tested at Mount Sinai, also from Emma's map. And this is one of the early before and afters, and another. And I actually don't know if those are from dupilumab or the anti-IL-22, but we've seen recently dramatic improvement, much slower than with dupilumab, but dramatic improvement with IL-22 as well. This is one that we haven't done so well with, TSLP, which you'd think might work. And Emma's now been able to phenotype the patients and identify many in which IL-17 is particularly effective, and has submitted reports of patients treated with drugs that block either IL-23 or IL-17, and thus indirectly block IL-17, and are able to reverse, and this is actually her case report, have been able to reverse atopic dermatitis fairly profoundly and quickly. So you see that case report there. So as I give this talk, I always go back to Infliximab, which was a Genentech drug. And this was the announcement that came from Genentech when there were 3 reports of progressive multifocal leukoencephalopathy, so very rare, almost unheard of viral infection, which only emerges in the setting of immunosuppression. So very clearly, it had to be out on the market for several years and used in thousands of patients before we realized this, and then it was taken off the market. So it's early in the life of these drugs, and we're excited about them. We don't know what it'll be in 5 years, but certainly the future is promising. We do think we'll have safer treatments. If any of you do use biologics, I'm going to give a plug here for a registry, which is called the Corona Registry. And this is a registry that now the FDA that many companies are with new biologics are using, because the FDA has mandated that they have to minimize risk and come forward with a plan to follow patients long term, so that we do know when rare side effects like that come up. And so here's something where you actually get paid very well to do something that's good for society. It's called the Corona Registry. It's in partnership with the National Psoriasis Foundation. You get paid $400 for a first visit, $300 for follow-up visits, and your patients have to fill out a questionnaire that takes about 10 minutes. So it's good for, certainly good for data collection on these patients, and you get compensated for it. And if you're interested, it's corona.org, or there's a phone number listed there. Thank you very much.